So I will report on the highlights of heart failure, and I used some of the slides prepared by my friend Professor Michael Böhm from Germany, together with additional slides. And I am going to review a number of topics, and for the sake of time, I will move immediately to the first one. You may be aware of the fact that in heart failure and reduced ejection fraction, there is a question mark on the benefit brought by beta blockers in patients with reduced ejection fraction in atrial fibrillation. And actually, there are two meta-analyses which were done from the large clinical outcome trials in heart failure and reduced ejection fraction, which suggests that in patients in atrial fibrillation, beta blockers are no more beneficial. And I would like to report to you two studies which were presented in Barcelona. The first one comes from the ESC heart failure large registry. It's a registry and not a clinical trial, and they looked at this issue. The first message brought by this study is that heart rate is associated with outcomes. You can see here in this population that patients who had a heart rate markedly elevated had a poor survival compared to those with mid-range or rather low heart rate. And this was true not only for all-cause mortality, but for the composite of all-cause deaths or heart failure hospitalization. Now, what did they observe is in patients in sinus rhythm, in patients in heart failure and atrial fibrillation, those treated with beta blockers had a better survival than those without beta blockers, with a hazard ratio of approximately 0.5. And this was true not only for all-cause mortality, but also for the secondary endpoint, which was all-cause mortality or heart failure hospitalization. So this observational study contradicts the meta-analysis that I mentioned. Now, the second study comes from Sweden. It is made only of patients after a myocardial infarction. And yet, as you can see, this registry enrolled more than 40,000 patients with an acute myocardial infarction. Not surprisingly, most of them, 90% or so, were discharged with beta blockers. But the first interesting information is that nearly 1 in 3 had stopped beta blocker at 1 year. And there is a difference in survival benefit in those who are adherent, dotted line, compared to those who are not adherent, continuous line. So it seems that after a myocardial infarction, being adherent to beta blocker therapy is associated with a good outcome. And interestingly, this is true for all kinds of ejection fraction. Normal ejection fraction, you have a risk reduction of 16%. In reduced ejection fraction, the risk reduction is 30%. And in patients with heart failure and reduced ejection fraction, the reduction of risk is also approximately 1/4. Now let's look at the benefit of beta blockers in this post-myocardial infarction based on ejection fraction. In this registry, the investigators found again what is well known, which is that ejection fraction is a strong predictor of mortality. The reference is 35%, and you can see that survival in those with low levels, mortality in those with low levels of ejection fraction is markedly increased. And they looked at the hazard ratio by 5-point decrease in ejection fraction in patients in sinus rhythm and in patients with atrial fibrillation. And you can see that there is a significant correlation, but the level of increase in the risk is lower in patients in atrial fibrillation. And then they looked at the potential benefit of beta blocker therapy in these patients based on the level of ejection fraction. This shows in patients in sinus rhythm all-cause mortality in blue and cardiovascular mortality in red by ejection class. And you can see that in patients, once again, in sinus rhythm with very low or with mid-range ejection fraction, there is a risk reduction brought by beta blockers. Not so in those with preserved ejection fraction. But if you look at the population in atrial fibrillation, you can see that the benefit brought by beta blockers goes away. So I think these two studies are a bit contradictory, and it seems to me that there remains a question mark on the real benefit brought by beta blocker therapy in patients in heart failure or with reduced ejection fraction. Let's move on to the second topic, which is the use and the risk of mineralocorticoid receptor antagonist. And this is again the Sweetheart registry, and in this registry the investigators could enroll 70,000 patients after a myocardial infarction, once again, so it's not all a broad range of heart failure, and only a minority of these patients were treated by a mineralocorticoid receptor antagonist. And the first information is that when you look at the overall population, there is no benefit in patients receiving a mineralocorticoid receptor antagonist compared to those not treated by a mineralocorticoid receptor antagonist. But of course, the investigators tried to dissect this observation better. First of all, they looked at a potential difference between patients with chronic kidney disease or without chronic kidney disease. You can see that there is a trend in this forest plot for a greater benefit in patients with chronic kidney disease, surprisingly, but the difference is not statistically significant. And the other important information is that when they looked at the benefit of mineralocorticoid receptor antagonist by class of ejection fraction, most of the benefit was confined to those patients who had a low ejection fraction. So in a sense, this study is reassuring and tells us that after a myocardial infarction, only patients with a low ejection fraction are sensitive to mineralocorticoid receptor antagonists. The third topic is, does potassium matter in heart failure patients? And there was this interesting study from the United Kingdom, which was coming out of a large database from which they could analyze more than 23,000 patients with heart failure. And what they did is to look at the relationship between serum potassium and long-term outcome. And they found this interesting U-shaped curve for all-cause mortality, but also for MACE. And you can see that in patients who had at some point hyperkalemia, there is a marked increase in all-cause mortality. But this holds true also for patients who were outside the lower range of normal kalemia, and here again there was a marked increase in all-cause mortality. The relationship is more flat for MACE, but it exists also. So this means that serum potassium should be regularly checked and monitored in patients with heart failure, because it appears to be in a population of heart failure patients associated with outcomes when it is outside the normal range. And this second study from Denmark is very much in line. In this study, the investigators looked at the 6 months outcome following an episode of hyperkalemia, and it is outlined here. You can see that whatever the outcome considered, there is a marked increase in the risk of rehospitalization, death, cardiac arrest, hospitalization in intensive care unit in patients who had experienced hyperkalemia. So this is reinforcing what I said about the previous study. We should monitor carefully serum potassium in patients with heart failure. Is adherence to guidelines important regarding outcomes? You may know that there are some short-term studies, no more than 6 months, which suggest that there is a relationship between a good adherence to guidelines by physicians and clinical outcomes for patients with heart failure. We did this analysis in a large population worldwide of patients with heart failure and reduced ejection fraction below or equal to 40% and more than 18 years of old, and we looked at the 18 months outcomes. We were able to enroll 6,700 patients worldwide, and I would like to take the opportunity of this meeting to thank the Chinese investigators who enrolled 900 patients. So what did we observe at 18 months? There is a strong relationship between a good adherence by physicians to guidelines and all-cause mortality, cardiovascular mortality, and also the composite of cardiovascular deaths or cardiovascular hospitalizations, as well as heart failure deaths. And when we did a multivariate analysis, you can see that the increase in the risk of all-cause deaths or cardiovascular deaths in those who are in the moderate or the poor group compared to good is in the range of 50%, so it is a lot at 18 months. And the risk of heart failure hospitalization or heart failure death is also increased by 20%. So we conclude from this analysis at 18 months of follow-up that indeed physicians' adherence to guideline-recommended medications in heart failure and reduced ejection fraction is very important, and that it influences to a great extent the outcome of our heart failure patients. There were a lot of studies about diabetes, and I will just mention this one. You are aware of the fact that there is a new class of anti-diabetic medication which is called the sodium glucose cotransporter inhibitors, and the first agent is called empagliflozin, which have been tested now in 2 different trials. And in one trial, the first one called EMPAREG, there was a dramatic reduction in heart failure events. And we don't know at the moment exactly what is the mechanism of action of the reduction of heart failure events in diabetic patients at very high cardiovascular risk. There was a sub-analysis of the EMPAREG outcome presented by David Fitchett, and one of the hypotheses was that the favorable effect on blood pressure of this new class, which reduces blood pressure by approximately 2 millimeters of mercury, might be beneficial. And they corrected they made an adjustment of their analysis based on blood pressure, the level of hemoglobin A1C, and also LDL cholesterol. And you can see that there is a remarkable concordance of the reduction in the risk of the primary outcome, whatever the adjustment made. And so I think that at the moment, we do not know exactly what is the mechanism of action of this class called gliflozins. Here are listed the many mechanisms which have been suggested, but which need to be confirmed before we can make any definite conclusion. And I was in particular interested by this basic science abstract which was presented in Barcelona, in which in a rat model of myocardial dysfunction following doxorubicin, empagliflozin reduced significantly the myocardial dysfunction, suggesting that there might be a direct myocardial effect, but we need to learn more. Exergaming. What is exergaming? It is a way of encouraging heart failure patients to do fancy exercise by any means, Nintendo, Dance Dance Revolution, or whatever. And there was a randomized trial presented by Tini Jasma. She is a Dutch nurse who is working presently in Sweden. And she did a randomized trial to test the benefit of exergaming on exercise capacity. And in this trial, she interestingly found that at 3 months, there was a significant improvement in exercise capacity measured by the 6-minute walking distance. So probably exergaming, which is fancy once again, could be beneficial to our heart failure patients, elderly heart failure patients, when exercising. I would like to finish by an interesting study on atrial fibrillation ablation in heart failure with reduced ejection fraction. You may recall the fact that approximately 10 years ago, there was an important trial called AFCHF, which compared rhythm control compared to rate control, and rhythm control was achieved through cardioversions. And this trial was very disappointing because there was no improvement in the primary outcome, which was cardiovascular mortality in patients in whom rhythm control was achieved at any expense. And on the contrary, there were a trend for more hospitalizations, which were due to the fact that these patients had to be rehospitalized for repeated cardioversions. And also, there was absolutely no benefit on any clinical outcome, including stroke or worsening heart failure. And in this context, it was interesting to look at the Castle AF trial, which enrolled approximately 400 patients, randomized either to conventional therapy by antiarrhythmic drugs or to ablation, and they were followed up to 60 months. These are the inclusion criteria of Castle AF: symptomatic paroxysmal or persistent atrial fibrillation, failure or intolerance to at least one antiarrhythmic drug, or unwillingness of the patients to be treated by antiarrhythmic drugs, low ejection fraction, mild heart failure by an NYHA class, and all these patients had been implanted an ICD-CRT with home monitoring capabilities for any other reasons. This is the results in the two groups. In green is the control group, in red the ablation group. Not surprisingly, during the course of the trial, there was a significant reduction in the atrial fibrillation burden in favor of the ablated patients. But what is interesting is the result on ejection fraction. You can see that at 12, 36, and 60 months, there was an improvement in cardiac function in those patients who were treated by atrial fibrillation ablation compared to conventional therapy. And importantly, there was a significant improvement in the primary composite outcome, which was made of all-cause mortality or heart failure rehospitalization. These are the two components of the primary outcome. You can see that there is some delay before the two curves diverge, but it is in favor of ablation compared to conventional therapy with a marked risk reduction. And the same holds true for worsening heart failure admissions, which were significantly reduced in the ablated group. So what should we conclude from this study? I think, should we promote atrial fibrillation ablation in heart failure patients with reduced ejection fraction? I think it's probably a bit too early, because you may have noticed that some patients with paroxysmal atrial fibrillation were enrolled in this trial, but nevertheless, I think it is a rather good news, and it suggests that additional studies should be done in this setting. So these are the take-home messages for heart failure. So atrial fibrillation influences outcomes in heart failure, and the effect of beta blockers remains a bit of a question mark. Beta blockers post-myocardial infarction prevent the occurrence of heart failure with reduced ejection fraction, and they reduce mortality in mid-range ejection fraction, but the benefit in AFib is not confirmed. Mineralocorticoid receptor antagonists work in high-risk patients, including those with chronic kidney disease after a myocardial infarction. Hyperkalemia is really a problem and should be carefully monitored in heart failure. Adherence to guidelines by physicians is associated with favorable 18 months outcome in heart failure with reduced ejection fraction. For sodium glucose cotransporter inhibitors, outcome trials are underway, and the mechanism of the benefit, particularly for heart failure, remains unclear. Exergaming can be a fancy way of encouraging our elderly heart failure patients in order to improve their exercise capacity. And finally, atrial fibrillation ablation is beneficial in heart failure with reduced ejection fraction. Cześć.